maji. Imekuwaje na mipango yao ni ipi? Nampisha Sam Gituku na Nimro Tabu.
All right, thank you so much, Lulu and Jeff. And I want us to start by looking at two issues. That is the plan and the action taken by the government so far. This was in the Kenya Kwanza manifesto. For instance, on the question of health promise, there was a promise to make sure that primary health care becomes fully publicly financed. There was a promise that there will be universal seamless health insurance system, and there was supposed to be mandatory NHIF, meaning the health insurance fund, the contribution has to come from every person, and it's essentially to cater also, this was to be the primary cover across the country. But then also there was supposed to be a national cover for chronic non-communicable diseases, and of course that was supposed to be funded through the insurance levy from what would go to the National Health Insurance Fund, but also from government contribution. So what has the government done so far? They have, the cabinet has passed or endorsed, is it cleared, 4 bills to go to the health sector. One of them is the Digital Health Bill 2023, there's the Primary Healthcare Bill 2023, there's the Social Health Insurance Bill, and there is the Facilities Improvement Financing Bill. These bills are supposed to be introducing different funds, but also to outline how services are to be offered in different facilities. But there's something interesting. There's a proposal to come up with a social health insurance fund, which will be mandatory, but there has also been the talk about amending the current NHIF regulations to introduce a rate of 2.75% on every person who is salaried, but also even those that are not salaried, there would be means testing to ensure you determine how much they should be paying to the Social Health Insurance Fund, and then every person has to be a member of that particular Social Health Insurance Fund. But Waziri, now that you're here, and we have seen the 4 bills that are being proposed currently in the stage of public participation, let's talk about the rate of 2.75% contribution by those that are salaried. First of all, when does it take effect? And knowing that what is being debated now is the NHIF regulations, amendments to those regulations, how then will that tie to the Social Health Insurance Fund?
Thank you, Sam. Let me begin by highlighting the promise. You have highlighted it there, but let me just elaborate on it a little bit more. Why universal health coverage? Universal health coverage to ensure that all Kenyans access health care affordably without suffering any financial loss. And how are we going to do it? We are going to do it based on primary health care. In primary health care, you focus on preventing diseases, promoting wellness and health, and providing rehabilitative services. And that is the major shift in terms of what we want to do on healthcare. The current health system in Kenya is focused on curative services, where people want to seek services from facilities at the highest level, leaving those at the lower level. So we want to have a total paradigm shift on how we deliver healthcare, starting at the base. Remember, this is a bottom-up government. So for preventive and promotive services, we begin them at the base. And where is the base of health? The base of health is in the household. So what have we done? We have recruited and trained 100,000 community health promoters. Each community health promoter will be in charge of 100 households. That one community health promoter goes to 100 households. We have kitted that community health promoter with a kit that has basic first aid. It has water treatment tablets because we want to ensure that people are taking clean water. It has dewormers. It has basic testing. For example, for malaria, we have put inside the kit. They can also check your blood pressure, check the weight, and all that. That is what we have put in that kit. But equally, these community health promoters, each of them has a gadget. Remember, we said we are going to leverage on digitization. So each of the community health promoter has a gadget that they will be using to collect data from the household. This data will link up to the national headquarters. It shall be used in decision making. We shall use that data to do quantification of our products to know how much of each health product or commodity that we need to select. Having said that, as we move up from the household level, now we move to the next level of service, which is level 2, level 3, level 4. And we intend that we shall have primary care networks, that each and every Kenyan will be linked to a specific facility in terms of services. Why do we want to do that? So that we remove the queues from the higher levels of service. The queues you see at Kenyatta Hospital, not everyone you see there ought to be there. There are people who are there, yet they have gone for a cough or a cold. They make up the queue somebody who needs emergency care comes, or somebody who is critically ill comes, yet we have a cough and a cold on the queue. We want to ensure that the dispenser in Dagoretti is working. The health center in Dagoretti is working, and you are linked to it. By the time you go to Kenyatta, you must have been referred to go to Kenyatta. You first go through the lower level facilities. So we are developing what we call primary care networks. After we have the primary care networks, then now you move to the third level, which is level 3 and level 4, where now you go to access services, and lastly level 5 and level 6, which are the referrals. How we are going to do this, we have come up with the 4 bills. The primary healthcare bill that will take care of the lower level and organizing them into the primary care networks. We have come up with the digital health bill that then assists us in terms of leveraging on technology, but equally that we are able to provide services digitally. A specialist sitting in Nairobi can read a CT that has been done in Trans Nzoia and give a prescription or make proper diagnosis for a disease. We have the FIF, Facility Improvement Fund. Why Facility Improvement Fund? That we have funds that are generated at levels of service. Each facility generates funds. But in most cases, these funds are not plowed back into the facilities. So we want to use the FIF to ring-fence the funds so that if you collect funds from health, you use them for health. That will not collect funds for health and take them to go and build a road elsewhere. They have to be brought back to commodities. Then lastly, the social health insurance bill. Social health insurance bill is where your 2.75% comes in, which I believe that was your question. This social health insurance, we have charged the 2.75% is on income, whether you are informal or informal. We will have a means testing where we determine what is your income. Then we apply 2.75%. But I also want to clarify. I have seen people saying that, so that means somebody will pay 100,000 plus. No. We have a cap of 5,000 shillings. The minimum is going to be 300. And those who cannot pay, then through the means testing as determined by government, will get subsidy. Government will be able to pay for them. But remember, from the bills, the primary healthcare will be publicly financed 100%. That is level 1 and level 2 of health services.
Just clarify there, because
yes.
So you said there's a cap of 5,000 shillings.
Yes.
So the president had spoken about those that are earning high will have to pay higher.
Yes.
And he had said that because an estimate of 1 million shillings, 2.75% will be 27,500. So that is no longer the policy.
Subject to.
It is subject to. But we have had discussion. Remember, when we started that, we have been subjecting these bills to public participation. So we have received reviews from the public. Equally, we have done our workings in terms of providing the healthcare. That if indeed we manage to prevent diseases and promote wellness, then we do not need to invest as much. By the way...
So the cap is 5,000 shillings?
5,000 shillings.
And how will you calculate the means testing that you just talked about on other incomes that are not based on salary?
We have an algorithm. First, where we have begun is we have developed an essential package. An essential package then indicates what a patient is entitled to when you go to a health facility. Besides preparing an essential package, we have done costing, that we know how much a service will cost. That if you are treated malaria in Trans Nzoia, you are treated malaria in Nairobi, you are treated malaria in Nyeri, it is one cost. So we are going to have a control on the costs. At the same time, we know what is the package that is going to be given to you. So now we have developed an algorithm, and we have gotten support from World Health Organization in developing an algorithm that then will be used to a means testing on your income. And that is what is going to be used to determine what your income is and apply the 2.75% to it.
Sam, I want to really weigh in on this issue.
Okay.